Good morning, everybody. I'm delighted to be here this morning to take part in this wonderful event that has been organised by the team at Spinal Injuries Ireland. Eimear Smith is my name, as Jack told you. I work at the National Rehabilitation and the Mater hospitals in Dublin, and many of you are known to me. So it's wonderful to see you all here this morning. So following on from what Marco has just spoken about, where are we in the Irish context as regards research into spinal cord injury? Well, the first thing to acknowledge is that I know that many of you who are here today haven't had a spinal cord injury of traumatic origin, but of non-traumatic origin. And that's very important because a lot of what Marco has spoken about and some of what I will speak about concerns traumatic spinal cord injury. And we know that non-traumatic spinal cord injury is very underrepresented in the research. So when I think back on my last 15 years in my current role, it's really sobering to think about the fact that we haven't had any major developments resulting in any neurological improvement for people who sustain a traumatic spinal cord injury. And when I say that, I'm thinking of neuroregeneration. So something that we can do to make the cells within the spinal cord grow back, as many of you often ask me about. We haven't had anything in terms of a big breakthrough. However, what we have got a little bit better at is neuroprotection. So what neuroprotection means that we are stopping secondary damage from occurring and thereby laying the foundations for more spontaneous neurological recovery. So, for example, we've got much better at recognising the need for early surgical decompression when someone has had a traumatic spinal cord injury. We've got an awful lot better at optimising blood pressure management, particularly for people with cervical level spinal cord injury in the intensive care unit. And in the last couple of years, we've also got an awful lot better at recognising how common dysphagia or swallow problems are in people with a cervical level spinal cord injury. And why is that important? Well, that's really important because if people have a swallow problem, they're more likely to get a pneumonia. And we know that pneumonia is associated with stopping neurological recovery. So really, really important that we identify swallow difficulties and manage them appropriately. So as clinicians, I think we've made great strides in those areas, but like I say, there have been no major breakthroughs. And it's not for a want of trying. So as Marco has spoken about some of the more recent trials, but there have been clinical trials going on for 40 years or more. So we've had trials on steroids, we've had trials looking at different types of stem cells, so like oligodendrocyte progenitor cells, we've had autologous Schwann cells, we've had growth factors, but as I say, sadly, none of them have resulted in any major developments in terms of neurological recovery. What has probably improved is our understanding of the natural history of spinal cord injury. So what's likely to happen to somebody in the weeks and months after they have a spinal cord injury? We're much better now at predicting the likely outcomes. So whether that's a C5 ASIA impairment scale A injury or a T11 ASIA impairment scale C, as clinicians, we now have better predictive models and better what we call prognostic indicators that we can use. And as Marco has also touched on, our scientist colleagues have got an awful lot better at understanding what exactly is going on in the spinal cord when someone sustains a spinal cord injury at a cellular level. So what cells are the most damaged? What chemicals is the body releasing around the cord or in the body in general? What cells move into the damaged area of the spinal cord? Are they doing good or are they doing bad, like causing scar formation? And because of that better understanding, and it's not complete, we don't understand everything, but it's better. And with that, we now have more labs globally looking at potential therapeutic interventions to help the recovery within the spinal cord. And two of these labs are here in Dublin, in the Royal College of Surgeons in Ireland, or CSI, and in University College Dublin, UCD. And thank you to my colleagues in the RCSI for sharing some of these slides with me this morning. And some of the young scientists are with us today in the audience, so it's great to have you present. So what the scientists in the RCSI are looking at specifically is the use of a scaffold. And a scaffold is a three-dimensional structure which is used to facilitate the delivery of cells and drugs and genetics and growth factors. So specifically, in a spinal cord injury, the idea would be that the scaffold would contain stem cells and also some very tiny particles called nanoparticles that are responsible for causing genetic manipulation. So changing the genetics of some of those stem cells to help regrowth of the cells within the spinal cord. But a unique aspect of this research is the fact that they're adding electrical stimulation. So Marco talked about electrical stimulation being applied on the cord and outside the body. So why not think about adding it into the cord? And that's what the scientists in the RCSI are adding to their research. So they're looking at putting electrical stimulation into the scaffold with the cells and the genetic modifiers that I've just spoken about, because that combination has been shown to improve the growth of nerve cells. So the idea would be that they will implant this scaffold, a three-dimensional structure, into the spinal cord at the area of the damage. And within that scaffold, you have that combination of treatments, the cells, the genetic modifiers, and the electrical stimulation. And in the lab setting, it has been shown that this combination does improve the growth of nerve cells or neurites. Now, positives and negatives of this. Well, positives, first of all, is this is what we call a combinatorial therapy. There are multiple potential targets, and if you've got more targets, there's probably a better chance that you're going to hit the right one and have a good outcome or more chance of neurological recovery. Let's not say negatives, but let's say the reality is this is still happening very much in the laboratory setting. And as Marco told you, 14 years to get from the preclinical to the clinical. It's a very long time. So we're at that stage with this research. It's in the lab, under the microscope, let's say, in a Petri dish. So very far away still from being implanted into a patient with a spinal cord injury. The other challenge is that with a combinatorial therapy, it is more challenging to get through the regulatory authorities. So Marco talked about the FDA in the US, we've got the CE, and in this country we've got the Health Products Regulatory Authority, we've got the European Medicines Agency. So with the combinatorial approach, it is more challenging to get through those regulators, but you've got to start somewhere. And this is a wonderful start that the guys in the RCSI are making to this. Another unique aspect of the research in the RCSI is the fact that we have patient and public involvement, so a PPI advisory panel as part of this work. Now, PPI is something that in the last number of years has gained momentum in the clinical setting. So specifically, it would mean that people with a spinal cord injury are involved in designing the research, in conducting it, in rolling out the results. And as I say, that's probably mainstream now in all clinical research, but not so much in preclinical research. So that's something that we have done with the RCSI project. And as a result of that, so as a result of having people with a spinal cord injury involved in this research, we have shown how we can improve the relevance of this research. We've also shown that by increasing the exposure of people with a cord injury to this lab-based research, that the chances of the misunderstanding of the results are reduced. And we've also identified some barriers to people with a spinal cord injury taking part in this work. So, for example, the lab might not be accessible. That's something that needs to be overcome. There might just be disinterest, that people don't want to do it. And there's also a real sense that a fear of hope being lost if the results are negative. Another part of this work is the fact that we've engaged clinicians, so healthcare professionals who work in the field of spinal cord injury. And it's hoped that by doing that, we'll improve the translation of this work. So bringing it from the bench to the bedside. The people who work with people with a spinal cord injury will be able to contribute to that and make that process more straightforward. And finally, we have developed a set of principles for patient and public involvement in preclinical spinal cord research that have been published. And we're hopeful that perhaps other labs globally will look at these principles and they will engage more people with a spinal cord injury in their work also. So you can't just put this scaffold, once it's developed in a lab, into somebody with a spinal cord injury. Before you do that, you have to go through at least 2 animal models. And that's not necessarily as straightforward as it might seem. You can't just take the scaffold and put it into a mouse or a rat. There's a huge amount of regulation to be gone through before you do that. So the lab in UCD, under the leadership of Dr. Dervla Dooley, have worked with the Health Products Regulatory Authority here to develop a rodent model or an animal model of spinal cord injury contusion. And that isn't minor. That's a huge amount of work. So, for example, some of the ethical standards you have to go through, showing how you're going to look after that mouse or that rat with a spinal cord injury if they have pain or if they have signs of a urinary tract infection. It is an enormous piece of work. So it's super that this has been done because it's now done for the country. So let's say the scientists in the RCSI want to use a similar model. They can now do this because it has been done by one lab in Ireland. And another area that the scientists in the UCD lab are looking at is an alternative method of drug delivery into the spinal cord. So I've spoken about the use of a scaffold to deliver cells and drugs into the cord. They're looking at an injectable material, and perhaps at some stage in the future I'll be able to talk to you a little bit more about that when it's a bit further advanced. So finally, before I wrap up, I'm often asked, especially in the outpatient clinic, by people who are coming back to see me, I'm thinking of going to Thailand for a treatment, or I'm thinking of going to Costa Rica for an intervention. What's your opinion on that? Well, some general guidelines. This paper was published back in 2021, and it's for people with a spinal cord injury. Experimental treatments for spinal cord injury, what you should know. So it's a really, really good piece of work, and it's very well worth your while looking at it if you're thinking of going overseas for an intervention. I would recommend that if you're looking at a clinical trial, you use the scitrialfinder.net website. It will help you to find a trial most suitable for you and your level of injury, your age impairment scale, and so on. And it also includes some trials on non-traumatic spinal cord injury. The second point to make is you should never, ever be asked to pay to be part of a clinical trial. You may have to pay your transport costs, your accommodation costs, but never to be part of a clinical trial. Every trial should have a control group. So that means that you may not necessarily get the treatment or the intervention. You may be in the control group. And ideally, you should not know that. You shouldn't know whether you're getting the treatment intervention or whether you're getting the placebo. Nor should the researchers know that. And that's what we call blinding. And ideally, every trial would be fully blinded. Now, it's not always possible to have blinding of both researchers and the trial participants, but insofar as it's possible, blinding should occur. Because you actually won't be able to, you can't properly prove the outcome of a clinical trial if you don't have a control group and full blinding. A clinical trial in humans should have undergone study in animals or people with other conditions, and that safety data on that trial should be available to you should you want it. There should be no conflict of interest in any trial that you're involved with. So what that means is that if it's a drug, the researchers involved shouldn't have a company that has been involved in developing that drug, or the same for any electrical device, that the person involved in developing that shouldn't be one of the researchers on that study. And finally, you have a right to have fully informed consent prior to your participation in the study. So you should know everything about the possible outcomes, including all of the adverse effects that can occur, and what the outcome would be should you wish to withdraw from the study. So to wrap up, firstly, once again, an acknowledgement that for many of you out there, spinal cord injury of a non-traumatic origin is very underrepresented in the research, and much of what we are talking about today concerns traumatic spinal cord injury. On a positive note, we have a much better understanding now than we did, let's say, 20 years ago, of what's happening within the spinal cord when an injury occurs. And as a result of that, we have more laboratories globally looking at potential therapeutic strategies. I would say that patient and public involvement, so people with a spinal cord injury, can and now should be part of any preclinical or laboratory research, as it is with all clinical research. And finally, we need to apply the same standards to spinal cord injury as we do for other health conditions such as heart failure or cancer or anything else that is being researched. Thank you.